Hello and welcome to Everyday Medicine. I'm Dr. Luke, and I'd like to thank you for joining me on this podcast series where we share conversations with colleagues, exploring their special interests in medicine and bringing insights, ideas and advice which I hope will be applicable for our medical practices. In this episode, we have a conversation with a cardiologist about volume exercise in the heart. Is it safe? And for Australian audiences, listening does give you eligibility for your CPD, so log in and add this as an activity. And you may also consider journaling, reflection, and adding to the review and performance section in your CPD. Well, the Greek messenger Pheidippides famously ran 42 kilometres from Marathon to Athens, delivering news of victory in battle before dropping dead, still a young man. Pheidippides was undoubtedly fit and an accomplished runner, as he'd been a Greek herald messenger his entire life. Was his untimely death due to excessive exercising or unforeseen preexisting cardiac risk factors? Well, the standout story mirrors the sad death last year of champion athlete and Queensland Ironman Dean Mercer, aged 47 years, from an acute cardiac event after an early morning swim session. Was his death a consequence of his extraordinary training schedule or preexisting cardiac disease? The famous Australian Carney sisters were both forced to retire from world triathlon competition and their elite standing with life-threatening cardiac disease, similar to world champion triathlete Greg Welch. Notable athletes such as American marathon runner Ryan Shay succumbed from a fatal cardiac event at 28 years during Olympic marathon trials. Athlete authors Christopher McDougall, known for his book Born to Run, died alone on a trail run in New Mexico aged 58 years, similar to Jim Fixx, who wrote The Complete Book of Running and died in 1984 at the age of 52 from an acute cardiac event. Well, these notable cases raise questions about the insidious impact of elite endurance sport and volume exercise and raise concerns about cardiac rhythm disturbances and coronary arterial plaque rupture, as well as chronic inflammation in a condition some refer to as athlete's heart. Well, as compelling as this diagnosis may seem, the proposed condition athlete's heart, however, is not widely accepted. And indeed, quoting Andre Lagersh, who's an expert sports cardiologist at the Baker Heart and Diabetes Institute in Melbourne, there is no proven link between endurance sport and sudden death. To the contrary, athletes live longer. Endurance athletes and gold medalists live the longest. However, endurance athletes are about 2 to 5% more likely than the general population to develop heart problems, including rhythm disturbances such as atrial fibrillation. Dr. Lagersh urges us to remember the importance of separating public health from individual risk and reminds us that exercise in all forms reduces the risk of cardiovascular disease and diabetes and extends life. While any individual can have a heart attack, there are 20,000 deaths from heart disease per year in Australia. That's 1 every 10 minutes. Common things happen commonly. And about 1 per 100,000 people die of heart attacks during marathons. No conclusion can be drawn as a pre-existing condition in such cases was likely. In 2008, Lagersh conducted an echo ultrasound study on triathletes following completion of a race, demonstrating acute changes that recovered within days. He also demonstrated that about 12% of elite athletes in their 30s and 40s have little patches of scarring in their hearts. The significance of the scar tissue, however, is not currently understood. So many endurance athletes have a left ventricle capacity of 300 mils. This is 3 times normal, demonstrating a profound alteration of structure and functional capacity. However, again, the health implications of these big hearts is not known. A longitudinal study, dubbed the Athletic Framingham Study, commenced in 2016, is a collaboration between Australian and Belgian doctors and is focused on heart function measurements of high-level athletes. Now, these results are eagerly awaited and will greatly enhance our insights into endurance sports and heart pathophysiology. With a boom in participation in community marathons and triathlons, including half and full Ironman events, older entrants are enrolling that may have pre-existing cardiac disease. It may be wise for all to consider a cardiac workup before entering and competing. The question remains whether moderate exercise should be the goal, with caution for those entering elite high-volume endurance training regimes. As noted, studies are progressing, but to answer some of these questions, I was joined by cardiologist Dr. Maria Brosnan. Now, Maria is an elite athlete herself, having competed widely. She has strong interests in arrhythmias as well as cardiac physiology in elite athletes. She works at St Vincent's Heart Centre and the Baker Institute, as well as the National Centre for Sports Cardiology. She serves as a consultant for Tennis Australia, the AFL Draft, Rowing Australia, and several professional cycling teams. So please welcome her to the podcast. So, Dr. Maria Brosnan, thank you for joining me on Everyday Medicine. and for letting me hound you before you went overseas and then subsequently on your return.
Yep.
Maria, it's very kind of you to make time to join us. Maria, you're a cardiologist with a special interest in exercise and other things, and you're going to tell us a little bit about your current sort of project in genomics. But I really wanted to discuss today about exercise, how it affects the heart, what's considered to be healthy. I have a personal interest in this because my son's a triathlete.
Mm-hmm.
And, he's doing incredible amounts of exercise on his bicycle and in the swimming pool and also running. So I'm going to sort of try and get some of this information so I can assist him as well. But
yeah.
Can you tell us a little bit about your career? How do you tell us about your journey, Maria? Take us through how you've got here and what your current project is at St Vincent's.
Yeah. So I was. So I guess I was a pretty competitive sort of junior triathlete, and when I left school, that was sort of what I wanted to do. So I didn't pursue academia, and then. So just ran into injury trouble. So I ended up studying sports science, and then after that was lucky enough to spend 1999, so a pretty cool year to be at the Institute of Sport in the physiology lab. So I spent that year with Dave Martin, who at the time was the cycling physiologist.
Just pre-Olympics, yeah.
Yeah. So they were actually developing the test for the urine test for EPO in the lab.
Oh.
So half the lab staff were on EPO. No, it was just a really fun time, and cool things happening. So I did an honours project in altitude physiology with the women's cycling team.
Oh.
And sort of knew that I really liked research, but I needed to get a proper job. So then I went and did medicine, but always had in the back of my mind that I would come back to research. And when I did medicine, I wasn't necessarily thinking cardiology at all, but I kind of fell into it. And then when I came to Melbourne to start my training, was aware of Andre Lagersche's research. He'd just moved to Belgium at that time for his postdoc. But that window of opportunity was there, and I still had contacts from that time in 1999. So, once I'd sort of was doing my cardiology training, was still thinking I wanted to get back into the research side of things, and really the sports cardiology side of things came about through that. So my PhD was largely based around screening, so screening athletes to see if we could detect those people at risk of sudden cardiac death. But in doing that, developed very good relationships with professional sporting teams and a really good understanding of athletes' heart, and that sort of moved straight into clinical practice.
Well, did you do your high altitude training in Colorado? Is that
No? So we were using a simulated. They still have an altitude house. At the Institute of Sport. Back then it was pretty rudimentary, so it was a big nitrogen cylinder pumping nitrogen to displace oxygen.
I see.
And we would use that, so the athletes used to sleep in there, and one of us would have to stay up at night to make sure they didn't drift off to too high an altitude. But we would use that same methodology to simulate exercise at altitude. So my PhD wasn't necessarily effective living high, training high. It was actually living low, training high. So how does that impact your ability to exercise when you're under a normobaric hypoxic environment?
Okay, gosh, that's so interesting. And now you were talking a little bit about genomics, and you're looking also at the genomics of, I guess, cardiac disease. Is that really your interest there to try and tease out who's at most risk from developing atherosclerotic cardiovascular disease, or is it more the electrical side of cardiac disease? What tell us about the genomic research?
Yeah, so the genomic side of things isn't it's kind of the opposite. It's almost anything but coronary disease, although familial hypercholesterolemia is something that we do need to think about. But my sort of in the whole, looking after young athletic people, the conditions that do cause young people largely to run into problems are inherited. So inherited cardiomyopathies, inherited channelopathies or rhythm disorders.
Yes.
So purely through all the stuff I was doing with athletes, developed a pretty specific interest in those disorders. And then it became, pretty frustrating not having to, engage other services to manage or investigate the genetic side of things. And so what's happened in the last 12 months is that there's now a Medicare rebate for specific cardiac genetic panels. So that made, accessing testing a little bit easier. So I've gone ahead and employed a genetic counsellor with, broad-based experience in cardiac genomics and running a genomic clinic out of St Bees.
So could people, that's your kelpie in the background.
It's my dog.
We love dogs. We love dogs. Is that it? So doctors in primary care, general practitioners could refer to you, Maria. What sort of conditions would they be thinking about?
So if you've got a patient with a new diagnosis, hypertrophic cardiomyopathy is the most common inherited heart disease.
Yes.
And so if you think that's what they have, or that's what they have, but the family hasn't been tested or the sort of genetic basis hasn't been addressed, they're absolutely the sort of people. Other things like long QT syndrome, arrhythmogenic cardiomyopathy, these are rarer conditions. But I guess from a GP perspective, the thing that GPs might diagnose themselves or incidentally find when they've ordered an echo would be HOCM. And that sort of landscape for HOCM management has changed a lot recently too. So we have a new medication, a direct myosin inhibitor that's very effective in people with outflow tract obstruction. And so I'm running that program at St Bees as well. So from anything genetic sort of inherited cardiomyopathies, but
where there's a pedigree demonstrated, you might think about referring to.
Or even without a pedigree, if there's a clear diagnosis, you can be the index case without a clear family history. Yeah.
So, Maria, we've heard about people like Matt Welch, who was a triathlete, developing a cardiomyopathy. Lisa Curry-Kenny, I think, has got an implantable defibrillator. And then there were the Carney sisters, sisters, who I think, I don't know whether they both have deceased, have they? But when we're sort of thinking about those conditions and those people, they're obviously exercising at the extreme. We've got a familial pedigree there with the Carneys, but just tell us how you sort of what sort of conditions we should be thinking about people who are exercising heavily, and whether we need to be looking carefully at the family history and giving our patients advice. There's a lot of questions in there, but just take us through.
You've picked out some pretty specific examples. And, they're not that's for people who've done high volume endurance exercise in their lifetimes who've manifest with disease. That's not a big numerator on a denominator. They are the exception to the rules, and without talking individually about those cases, there's not a I guess one of the things I think is really important to get across is that we spend most of our time as cardiologists trying to get people to exercise. And I always say any exercise is good exercise. And there really isn't a cap that we put on the amount or volume that's good or bad. Until someone has a problem, or unless someone has an underlying genetic predisposition to a specific heart problem that might be exacerbated by exercise. And those conditions are actually very rare.
So if we just think about high volume exercise, and I'm interested in your comments there that you, as a cardiologist and with a special interest, you're not specifically warning people if a triathlete comes to you and says, Dr. Brosnan, I'd like to have a talk with you about, I don't have any family pedigree, but I've heard about these index cases that are unusual, yes, very, very small denominator, but is there something that I should be watching out for or being careful of? Do you immediately try and reassure them, or how do you approach this, given that triathletes today at that very elite level are riding, running, swimming very, very large amounts of, they're doing huge kilometres, whatever, and lots of hours exercising. What's your approach to all that? What's your advice? So
immediate reassurance in the absence of any symptoms or family history of concern, immediate reassurance. Right. The reality is that even people who do really high volume, high intensity exercise, it's a good prognostic indicator for the rest of their life. They're much less likely to have adverse cardiovascular events. They're much more likely to live longer. The one little sting in the tail is potentially a higher incidence of atrial fibrillation. Yeah. But that said, more of an annoying thing than a serious thing because of their other, their good sort of the rest of their cardiometabolic profile being so good. Even if they have AF, it's less likely to cause strokes and adverse outcomes. So, the thing that you probably hear people talk most of, and the thing that really is more common in people as they get older who have done very high volume, high intensity exercise, e.g. rowers, cyclists, potentially triathletes. There seems to be a lifelong cumulative exposure that potentially potentiates things. But even then, it's not something that we, in the absence of symptoms, that we really go looking for. But in someone who presents with symptoms, it's quite different. First of all, like having said it's complete reassurance if they presented to you as a worried asymptomatic individual. If they presented to you with palpitations, you treat them like any other patient, but understanding when you do those basic investigations, you expect to find pretty significant cardiac remodelling, because if they don't have that significant cardiac remodelling, they're probably not an athlete. And then the sort of nuance is in figuring out what is healthy remodelling and what might potentially reflect a pathological process.
What do you mean by cardiac remodelling? Are you talking about left ventricular hypertrophy, or what are you referring to?
No, so what we generally see and would expect to see in someone who's had a lifelong history of high volume, high intensity exercise, so any of those sort of sports I've mentioned before, we tend to see really balanced cardiac remodelling. So everything's big LV, big RV, big atria. Sometimes RV a little bit bigger than the LV because the RV is thin-walled and a little bit more susceptible to stress. So not unusual to see the right ventricle even being slightly bigger than the left. In a sedentary person, it's like half the size of the left side. What would be unusual if only one of those chambers were enlarged, or just the atria or just the LV? That would be more indicative of potentially being a disease process. But, you get pretty used to seeing some pretty massive hearts. But, the things that would reassure us would be, absence of symptoms, normal augmentation of function with exercise, lack of, serious rhythm problems. But, there's obviously with everything in medicine, there's overlap between physiology and pathology. And that's the sort of nuance of what we do, is figuring out what might actually be more reflective of pathology. But a lot of what we do is reassurance.
The atrial fibrillation you're speaking of, can you explain the mechanism there? I'm guessing it's
I would like to, but we don't know for sure. I mean, we know that, endurance athletes get massive atria, massive hearts, but not everyone with massive atria or massive heart gets atrial fibrillation. Assessing fibrosis of the atria is very difficult. Such a thin-walled structure, we can't really assess that very well. There's clearly a correlation between volume and intensity load over a lifetime and the propensity for atrial fibrillation, but we don't understand all of those mechanisms yet. We think there's probably, like with anything, a little bit of a genetic explanation, but not a monogenic one. So we haven't seen so far these people presenting with monogenic causes of, cardiomyopathy. But Andre actually presented a late-breaking trial at ESC, so the big cardiology conference in Europe in London a couple of weeks ago. And that's some preliminary data looking at polygenic risk scores for atrial fibrillation. So these are, tiny, single nucleotide polymorphisms that we know are common in a general population with AF. If you look at those in an athletic population with AF as compared to a general population, they're more common in the athletes. So there probably is some sort of genetic underlying basis that means that some athletes get more remodelling and more atrial fibrillation than others, but we don't really have it. It's way, way, way off being something that we'd use as a clinical predicting tool, and it probably will never get there. But sort of makes sense that it's a combination of the environmental stress you put on your heart, plus some underlying genetic predisposition to AF that means that, some endurance athletes get atrial fibrillation.
I see. That's interesting. Is there a tendency for the heart size to reduce back toward its sort of pre-exercise level? Like you finish exercise, you've been an elite athlete, over time, is your heart going to go back to what it might have been?
So again, this is something that's not very well understood, but we are trying to investigate, but it's often pretty tricky because a lot of athletes never completely stop. But the evidence would suggest that in exercise cessation, there is some reverse remodelling, but not back to normal size. And so that makes you think, well, did this person ever have a heart that was normal size, or were they genetically predisposed to having a massive engine, and that's why they, fell into that sport? And we don't have the answer to that yet, but, you don't see someone just stop and their heart shrink back down to the size of a sedentary person. It just doesn't happen.
Well, one of my cardiology colleagues was talking about sort of the right ventricle tending to twist a little bit on its axis, and that the implication was that might be a factor that could lead to dysrhythmia. Maybe this is not correct information or understanding. Look, when we're talking about dysrhythmias, VTV, if these sort of things developing in these elite athletes, we're talking about perhaps I think you're letting me understand that there's perhaps a pre-existing channel disorder it's not specifically related to this hypertrophy that's developed or the dilation of the ventricles that's developed. Is that correct?
Yeah, I don't know what the twisting comment's about, but yeah, look, I think in a small proportion of athletes who do have not atrial fibrillation but serious ventricular arrhythmias, they, when you look at them more closely, they have a phenotype that's more in fitting with a cardiomyopathy, so a heart muscle problem, usually, rather than an underlying predisposition to heart rhythm problems. And then there are certainly some genetic conditions that we know exercise can accelerate disease expression. Yes. So ARVC is a classic. And this has been well sort of demonstrated even in relatively sedentary populations. If you take a family who have a gene that causes ARVC, and you look at the people who do more exercise, they present earlier than the people that are sedentary. So there's something, inflammatory or it causes adverse remodeling in ARVC and even left-sided forms of rhythmogenic cardiomyopathy that exercise might uncover. It's not the cause, but it might be the sort of uncovering trigger. And I think, again, without talking specifics about any of those other cases, it's probable that there is an underlying, has been some other underlying genetic predisposition that's led to that.
Yes, I see. Do you have a rule of thumb then in regard to someone who is exercising at a very high level? And it could be an AFL footballer, it could be someone who's going to do a Tour de France, enter the Tour de France, or perhaps be pushing toward that sort of level of elitism, triathletes, etc. Is there any place for an echocardiograph at some point? They have no family history and they're asymptomatic, they're feeling good, they're normotensive. Is there any role for echocardiography in these elite athletes that
only when it's mandated.
Yes, I see.
Only when it's mandated, and it often is mandated. And look, to be fair, that's how a lot of our understanding of athletes' heart has evolved, because we have all these athletes who are forced to have screening
in soccer and so forth.
Somewhat irrationally. Well, not just soccer, no. So the UCI, anyone you see riding the Tour de France has they have checks every year. It's alternating years, stress ECG. The next year is an echo ECG. And so on and so forth. So we have all of this, cumulative data on these athletes.
Right.
And then, we have athletes who we've enrolled for research purposes just to have a better understanding of what athletes' heart is. But no, the reality is that, and we don't see serial changes. You might see very subtle changes in and out of season, but and of course we do see people who have extreme cardiac remodeling, but in the absence of symptoms, that doesn't necessarily reflect disease. They are, a point of research interest, but for the even for the general, someone who's wanting to do their first Ironman, there's essentially no role in an asymptomatic individual for doing those tests. And in all honesty, if you send them to, a general cardiology department to have those tests done, they'll often come back reported as profoundly abnormal, because that department may not have an understanding of the extremes of what we accept as normal physiological adaptation in people doing lots and lots of exercise.
Right, okay. Well, I'm interested to hear about the Tour de France data. Do you know what that data has shown? Has it given us any insights or concerns to your knowledge?
No, it's just, no. I mean, I've been involved a lot with screening of the pro teams, and it's great baseline data for us to have. And if that, an individual ever has issues down the track, then that can be a useful reference point. We know these people have massive hearts, and they occasionally have a little bit of ectopy, and then later in life, sometimes even during their career, might have issues with atrial arrhythmias. But it is useful information to have, but it's not to say that we should be suggesting it for people who aren't having it, because they're enforced to do it as part of their medical checkup. So it's been informative, but I don't think it's something that changes our practice or the way we approach those subjects.
Well, that's very interesting. So we've got, thousands of people do these triathlons, half Ironmans and so forth. Generally, when you see these events, and the Melbourne ones, I think over 2,000, and Sunny Coast, my son's just been up there, 1,300 or 1,400 people. So there's many, many people that are engaged in it now. I think it's reassuring for me to hear that if someone's healthy and well, assuming that they've got some sort of basic health check at some point, blood pressure and so forth, that they really can be encouraged to continue on.
I guess the other thing one of the interesting things when you look at sort of adverse cardiac events in the general punter who's taken up, high intensity exercise, so decide to run their first marathon or do their first Ironman, they may not necessarily have the healthiest background health profile. They might be someone who's 45 and used to smoke, or have gotten into it because dad died of a heart attack when he was 50.
Yes.
So, you can't disregard all those underlying risk factors because the person seems ostensibly healthy. So it's quite a different population to look at than your, young professional athlete who's having mandatory screening every year.
Yes.
That said, there are no good screening tests for things like coronary disease, although they are the most common cause of adverse events in the general punter doing marathons, Ironmans, those sorts of things. So it's just at least having an awareness that, someone's risk factor profile, just because they've been, an ultra endurance athlete for 5 years, doesn't matter. It doesn't mean that their 10-pack year smoking history is no longer relevant. Those people will have to not ignore symptoms if they develop. And, as I said, if there's something like a much more common history, like a premature coronary vascular disease, just exercising doesn't prevent you from having adverse outcomes. So all the same rules apply for the person who's not athletic, that, you have to have your cholesterol checked if there's a family history. You're going to have your blood pressure checked. So often, they're probably the more pertinent things for the general population getting into high volume, high intensity exercise or competitive stuff, particularly, haven't necessarily been lifetime exercises, but getting into high volume stuff later on.
Is there any consequence in terms of blood pressure long term? I'm suspecting that there'll be great vascular bed development of these people. They probably have lower blood pressure as they become.
It seems to be that, the more exercise you've done, the better your cardiovascular outcomes are. And there's, and blood pressure is a reflection of that. It's very normal for us to see profound hypertension during exercise. That's the normal response, and sort of shows, elasticity of the arteries. But again, doesn't mean that you can't have hypertension. So no matter how fit you are, you can still have all these things that affect the general population.
Yeah. Yeah. Well, that's very helpful to run through that with you. Actually, it's extremely reassuring.
Yeah, no, I thought it might be. I think
I'm very reassured by that.
It's not an unusual presentation to have someone come and just be the worried well, like the worried well warrior who's heard about a story of, one of their idols ending up needing a defib. And as I said, it's important to have an understanding of those cases, but they're not the cases that should necessarily be at the front of mind.
Because it's a tiny, tiny number. Of all the people that do high volume exercise. Yeah, I agree. Yeah. Yes. Well, look, that's great. Do you still exercise?
I do. Yep. I would do as much as my time allows. I like doing big things. I just I was in Europe for a week and sort of had 6 days riding through the Basque Country and did some big mountains there.
Okay.
On the bike. Yeah.
Well, that's beautiful. Do you subscribe to the sort of, it seems like it's I'm not sure if it's just purely Norway, but the Norwegian athletes have this like strategy of training maybe 80% zone 2 and then 20% sort of flat out zone 5. A lot of these sort of 5,000 metre, 1,500 metre runners seem to be doing that. Do you have any thoughts about that? I think
I'm not. It's a very long time since I've given any thought to a training program, and it's like anything. If you throw enough eggs against the wall, some of them won't smash. So any training program is going to suit some people and not suit others. Just like a lot of the old rowing and cycling training programs are just get them to as many Ks as possible. Some of them won't break, and they'll be the ones that we keep. But we understand now that not every type of training suits every person.
Yes.
Just like not every person responds to altitude training. So there's a lot more. There needs to be a lot more nuance with what works for different people. And I've a long time left this sort of high performance exercise physiology sphere. But I think that basic understanding is probably getting better. That it's not a one size fits all in terms of this really works. Go and do this. I think there's huge individual variability in what works for different people.
It's a bit like personalised medicine, I guess, isn't it? It doesn't necessarily work for whatever strategy we have. It does vary significantly. Maria, that's. Thank you very much for enlightening me and taking the time to talk with me. I just want to leave you with one question, and that is the most exciting thing you had to do in Europe. But maybe it was your bike riding to the back, which I've never done. But that sounds fantastic. But give us a highlight.
Oh, highlight. Okay, so it would have been a highlight, and a lowlight would have been the Calder. Oh gosh, what's it called? Bagagui. Calder Bagagui. It's the highest mountain in the Basque Country. So it's 27k climb. Last 10k's average is 10%, but last 5k's 12.5. And genuinely 12.5.
It's hard.
Not like summer's 4 and summer's 15. It's just 12.5%. And did it in the pouring rain and zero visibility at the top. But it was incredibly satisfying. Got to the top and found a shepherd with some sheep and a border collie who's doing the job that my dog should be doing rather than tapping at the back door. But yeah, it was like being in another world.
Are you a solo rider? Was that a solo?
No, my partner was with me, but I'm very happy to go out and ride on my own. But yeah, it's just it's whatever time allows, right? But it's a good way to see the world.
It's important for us all, isn't it, to do that, to exercise and keep ourselves fit and active. Well, thank you so much, Mary, for taking time to talk with me tonight. It's been very nice.
No worries, Luke. Nice
Thank you so much. Thank you.
Okay. Cheers. Bye.
Well, thank you for joining me on this podcast where we discuss with Maria Brosnan volume exercise in the heart. Is it safe? We're waiting for studies to clarify some issues, but it is reassuring to note that athletes in general live longer. I think it's important, though, for us to note that our patients who are entering sports events, perhaps who haven't exercised for a long time, such as half Ironman, and marathon events, probably should have some cardiac workup, perhaps a CT, calcium score, exercise echocardiograph and cardiac review. I think this would certainly give us reassurance. And then before they enter. Well, during the podcast series, we will be covering a wide range of topics. We have another specialist next week. A review of topics to be reviewed and comments about the conversation you've listened to are welcomed. Please join us. Email any queries you have to manager@gihealth.com.au. Thank you.